and it is on anger, hostility, and aggression. Your book does talk about that anger is just a normal emotion that everybody experiences. Some of us more than others, some of us more quickly to anger than others, but we all experience it. Sometimes people are uncomfortable expressing anger directly, so they kind of suppress that. Others are very easily expressible when it comes to anger. If handled appropriately, it is a positive force for reinforcing conflicts. It helps solve problems sometimes, and it definitely can help with decision making, especially as a parent. Sometimes you just have to get a little angry for things to happen. Yep, that's right. Okay, so anger, remember, it's broken down into a positive or a negative. So a positive is when a situation is truly unfair or wrong. You are allowed to be angry. A negative anger is when it is suppressed or expressed inappropriately. And remember that anger does help you alleviate, or it's cathartic, or it can increase your feelings of anger. So if you can't express it or deal with it, then it does build up, and we're going to progress on to something more. So the more violent or more non-appropriate display of anger is hostility and aggression. Hostility is verbal aggression, usually when you feel threatened or you feel powerless. Aggression is something that's physical. You attack somebody, you injure somebody, or you destroy personal property or something like that. Both intents are to harm or punish some other person, okay, or force them into doing what you want them to do. Some related disorders then to anger, hostility, or aggression. There are some comorbidities. So folks that have depressive disorders, we're going to talk about PTSD in a little bit, Alzheimer's disease, and some of your personality and psychotic disorders can have issues with anger, hostility, or aggression. So it may not be something that just is a standalone, but they may have a comorbidity with some other disease process going on. Your book talks about what are some etiological factors related to hostility and aggression. Well, of course, we could have problems with our neurotransmitters. Maybe they have a decreased serotonin. Maybe they have increased dopamine and norepinephrine. So they're always in that kind of hyped up mode at all times. Maybe there's some structural damage. If they have damage to their limbic system, damage to their frontal or temporal lobes, there could be issues with not being able to control themselves very well. They don't have very good impulse control. Psychosocial theories, some of those things, failure to develop impulse control, inability to delay gratification. We know as you're growing up and as a child, your parents, how you're brought up, your family, teach you those kind of things. School, teachers, all of those things help you develop impulse control, because if you have to wait in line with Johnny and Susie in front of you before you get yours, you do learn to delay gratification. You have to wait your turn. So, you know, those are kind of learned things that sometimes our people with hostility or aggression issues have never fully developed. Some cultural considerations. In certain cultures, expressing anger can be seen as rude or disrespectful, and in other cultures, it can be displayed as aggressive, agitated, or violent behavior. And, you know, it's okay. It's culturally accepted to do that. Medication or treatments for our patients that have hostile or aggressive behaviors would be our atypical antipsychotics. They help with their aggressive or impulsive behaviors. We can use antipsychotics like haloperidol. The reason why they like using the atypicals first is because they have less side effects. Haldol is a good medication to use, but it does have the side effects of like the Parkinsonian display or anticholinergic effects like hydration, vital sign issues, and then we can have problems with muscle rigidity. So the atypicals are what they like to try to utilize first. Other things could also be mood stabilizers, lithium, something like that. Again, we know side effects and we have to monitor blood levels with that. And then, of course, SSRIs, antidepressants, and then sedatives or hypnotics, something like the benzodiazepine family could also be used for this. So if you look at your book and you're looking at a nursing process, you know, what are the things that influence this aggressive behavior? Do they have a history of violent or aggressive behavior? How has it been handled in the past? How does the patient handle anger? And then the patient's behavior is looked at to determine what phase of aggression cycle that they're in. And your book actually has the cycles of aggression in it. You don't have a specific slide on it, but table 11.1, and it was on page 192. So somewhere in your 7th version or your 8th version of your VitaBac book, there is a table on the 5 phases of aggression that a person can go through. So data, risk for other directed violence. Do they have ineffective coping? And then, of course, our outcomes for all of our patients that fit into this category would be that they don't harm themselves, that they are not threatening to others, that they are not intimidating or frightening to others, that they're able to describe their feelings without being aggressive, and they can comply with the treatment protocols that the physician or the therapist has instilled. So we want to use the most effective, least restrictive, and we want to implement it as early in the cycle of aggression as we can. So if you're able, if you happen to have your book and you're able to look at that table, you can see that our phases are triggering, escalation, crisis, recovery, and post-crisis. And in the triggering, they're restless, they're irritable, they're pacing, you know, their voice may be getting louder. I can say that probably in the aggression cycle, I could be in the triggered stage quite a bit because my children force me to be in the triggered stage. But I really, for the most part, maybe get to a little escalation, especially when you're dealing with an 18-year-old that doesn't want to do what you want them to do. So I can say I have probably yelled, I have probably swore, I probably am not making a lot of physical threats because oftentimes people are bigger than me, but I will say I use the other things. Now at this point, I am able to get myself back under control. I really never get to the crisis state where I'm able to communicate. I'm not throwing things, I'm not kicking things, spitting, biting, those kind of things, not physically or emotionally out of control. I'm able to get myself under control in the escalation process. But I think if you look at your own life situation, unless you're very passive in your personality, there are probably things in life that have triggered you, things have escalated, but hopefully they have never gotten to the crisis stage where it becomes a problem for you. And even in the escalation phase, if it's happening all the time, it is an issue for us. We don't want to be like that, but there are certain things. I may tell my kids, you have pushed all my buttons and now mother is going to explode. And sometimes I do. So for interventions in that triggering phase, what can we do? Well, we can take a calm, non-threatening approach. We can be empathetic and listening. We can encourage verbalization of their expressions of their feelings. So it seems like you're this, can you tell me more about it? Suggest that the patient go to a quieter area. If the environment is upsetting them, Sometimes if you can remove your kids from a certain situation or you can remove yourself, you can calm yourself down. Sometimes people that are prescribed medications to calm themselves down can take something, step away from the situation, and within a half hour to an hour be calmer in their thinking and their ability to handle some type of issue. Activities such as walking, go take a walk, take a time out, those kind of things where you can kind of remove yourself from the situation. In the escalation phase, how would we manage this? Well, we would take control. We provide firm directions in a calm voice. Direct the patient to a quiet room, a quiet area, offer medication again. Let the patient know their aggression is unacceptable, especially if you're in a hospital or some type of confined situation. They have to be able to regain control and maintain that. It's not appropriate for them to be swearing, screaming, those kind of things. If it's ineffective, you might need to have help from somebody else. I know my husband works in a behavioral unit in the Columbus area. Now, their behaviors are more related to people that have had psychotic breaks. So they're unable to stay at home by themselves because they need direction. People that have been alcoholics and yet have encephalopathies from consuming too much alcohol. And so one day they may be very calm, the next day they may be out of control. And the nursing staff or the aides will come and ask my husband to assist because some of the men there are big and powerful and overwhelming to some of the staff. And yet my husband's 250 pounds and 6'3". And when he shows up, it's surprising that when he uses a calm voice, he can kind of regain control of some of those patients that are out of control because he can show force. He can show he's bigger and, kind of get them away from the situation and then kind of escort that resident back to their room or something and get them out of the area that maybe has triggered them or escalated it. And then for crisis phase, inform the patient that their behavior is out of control. The staff is going to take control. And really here we are providing safety for others and we're preventing injury to the patient and to others. And we only use restraints in these situations or seclusion if it's absolutely necessary, because oftentimes that does continue to cause the patient to be more in that crisis mode and out of control. Then in the recovery phase, after things start to they're able to regain a little bit of their physical and emotional control, we can talk about what triggered it. We can do some relaxation with them. Again, with therapies, we would explore alternatives to progressing to an aggressive behavior. If they were violent, then we do have to document any injuries. We debrief the staff. There are times when patients can be so out of control and you really don't have access to much to get them under control that sometimes we call the police departments. We're in our school situations and you have a teenager that's out of control, we call law enforcement, and unfortunately law enforcement will take them away and provide them with that environment to help kind of get them in that recovery or that situation where they're out of crisis mode. So sometimes we just can't handle it. We have to call for backup type support. And in the post-crisis phase, we remove the patient from any restraint or seclusion environment that we've provided. We calmly discuss their behavior, no lecturing or chastising, group therapies, activities they can return to, focus on appropriate expressions, and then try to resolve their problems and conflicts. We try to have them contract that they'll have non-aggressive manners in relationship to something that normally triggers them. And then when we evaluate, was the patient able to be diffused in an early stage? Did whatever we do work for the patient, or how could we have changed that? Will we be able to provide safety for them? Were we able to get them to kind of de-escalate before we had harm or threats or even property destruction? And it is amazing. Some of you are going to go into the school system, and I know we have, first graders that will destroy a room, third graders who will pick up desks, chairs, and throw them. Now, again, they have some comorbidity issue with that, but you don't think of a little first grader or a third grader being so violent and out of control that they're unable to effectively handle their emotions and their physical responses. But sometimes we do see that. I don't want to say we expect it in adults, but we see it in adults, I think, more often than we do sometimes in children. Community-based care, we really need to handle those comorbidities, regular follow-ups. We want to encourage that. Non-compliance is a big issue when it comes to any type of mental health issue. Compliance with prescribed medications. The cost of some of the medications may be a deterrent for some of our folks. Being able to get access to our medications sometimes can be a deterrent for folks. Sometimes family members are very supportive of them taking mental health medications. So we want to make sure that family focus is on understanding what's wrong with them. And then participation in community support programs. So maybe seeing outpatient group therapies for anger management. I'm trying to think, there's several movies on TV where folks are in anger management classes and are trying to deal with it. And they make kind of a fun response to it. But it is very serious because not only can the patient be harmful, but they can be harmful to others. And that's really what we want to try to avoid. So what do we do when we get done? You have to understand your self-awareness issues. How do you handle your own anger? I know mine is on a rare occasion. People get the best of me and I'm probably a little out of control. Do I use assertive communication skills, conflict resolution? Am I comfortable with the expression of anger to others? Depends on the situation. When you're in a position of power, I think expressing anger to others is a little easier than when you are not in the position of power to feel comfortable to express your anger. Say a boss and an employee, that type of relationship, because oftentimes you feel like maybe there's going to be a consequence if you display your anger or disapproval of something. Where if you're in the position of authority, I think it's a little easier to display that than it is when you're not. And then can you be calm and then non-judgmental? And I would say I do a little better at being calm. My non-judgmental piece probably needs some work at times, depending upon the situation. So self-reflection is always a good thing when it comes to mental health and mental disease processes. All right. There are some